Good evening, everybody. My name is Joan, and for my presentation today, I will be discussing opioid versus non-opioid analgesics for emergency department patients who complain of low back pain and how it affected length of stay in the department. Some background information. I worked in the ED for 5 years, and I observed that patients come in for various things, and one of the most common complaints being musculoskeletal pain, specifically low back pain. According to Anderson et al., low back pain makes up for 4.39% of emergency settings visits, therefore making it one of the top 10 reasons for an ED visit. In addition to that, approximately 62% of patients who presented with low back pain to the ED received an opioid analgesic as treatment. And this is significant because the opioid crisis is still something that impacts our nation today, and it impacts our practice. The Joint Commission issued a Sentinel Event Alert on the safe use of opioids in hospitals in 2012. So emergency department providers have to be cognizant and responsible when prescribing opioid treatments as the epidemic continues to impact our patients. The opioid crisis also continues to progress with over 150,000 opioid-related deaths between 2013 and 2017 alone. So this has become a public health issue. The ED is also an initial access for people seeking care. So for patients who use the ED for these reasons, we see that there's an increased length of stay. That leads to an increased use of ED resources, especially when opioids are administered. Anderson et al. Stated that an increase of 1.6 million hours per year in ED stay utilization occurred when opioids were given. So this indicates that when patients were given the opioid analgesics in the ED, they utilized greater resources like treatment rooms and clinician time. Length of stay also leads to overcrowding, which leads to decreased patient satisfaction and healthcare satisfaction rates, resulting in decreased quality of care and interventions. So my PICO question was, in patients admitted to the ED with low back pain, does the use of opioid medications as compared to non-opioid medications increase ED length of stay? My search strategy included using Cedar Crest College's online library. So EBSCOhost, I started with utilizing Cynol. I entered in the keywords or the phrase opioid epidemic emergency department. I also made sure to use Boolean phrase and expanders. I did limit the search to include full text links. I changed the publication dates to include literature from the past 10 years, and I filtered only peer-reviewed literature. I also chose to change the listing of the literature in order of relevance, and I changed my page options to include the title of the literature and its main content. So when I changed the format of the pages, it allowed me to view a snapshot kind of of the information included in each document instead of going into the document itself and looking at it. And from there, I was able to determine that 4 articles would be useful in researching the background of the problem. The literature search process for articles relevant to my PICO topic was a lot more challenging because it had very specific elements. So I did continue to use Cynol and the same filters as I had mentioned, and I did enter variations of the keywords opioid, back pain, length of stay, emergency department, and it surprisingly resulted in only 1 article that contained all of these very specific elements. My next plan of action was to utilize Google Scholar, which a few weeks ago we had discussed our search strategies, and a lot of my peers mentioned Google Scholar, so I decided to use that. When I typed in low back pain emergency department length of stay, that yielded 282,000 results, which is overwhelming. I did narrow down the search by customizing the year range for the literature in the last 10 years, and then I sorted out by relevance. That led to 15,700 results. Still an overwhelming amount of literature to sift through. So I did use specific phrases to find articles that had these particular phrases or words in them. And that resulted in 57 documents. I was able to sort the most recent and the most relevant from there. And then I was able to choose 8 articles that included all the components of my PICO question. For my synthesis of evidence, I chose 3 articles that were the most useful in answering my PICO question. So all of these articles had components of the question that were relevant and resulted in significant evidence to answer my PICO question. I also utilized Melnick and Feinout-Overalt's hierarchy to determine the strength of the studies based on the design of the study, and the Johns Hopkins quality rating scheme for research evidence tool to determine the quality of the studies. So the first article I chose was a cross-sectional study by Anderson et al., which does land lower in the hierarchy of evidence because of the design. So it was limited to observing data at a very specific time frame. However, I did find that it was still yielded good results based on its scientific evidence they provided. The authors also considered a lot of the variables that affected the primary outcome, which was length of stay, and they did attempt to minimize those variables. So if the length of stay was affected by things that were unrelated to the patient's conditions, they did try to minimize that. And they provided definitive conclusions based on the evidence in their research. So this study analyzed data from the National Hospital Ambulatory Medical Care Survey from 2014 to 2015 specifically. The sample size included adults older than 18 years old who presented to the ED and was diagnosed with low back pain. As a result, that sample size was over 8.5 million ED patients that they looked at. So one group had received opioid analgesia while in the ED, and the other group received non-opioid analgesia in the ED. The outcome compared the length of stay between these two groups, and the results showed that approximately 28% increase in ED length of stay for low back pain visits where opioid analgesics were given compared to patients who received non-opioid analgesics. The next article I chose was by Priano et al., titled Adjunct Analgesic Use for Acute Pain in the Emergency Department. This was again lower in the hierarchy because of its design. It's a retrospective chart review, and it looked at the sample size of 102 patients. So it was limited to specifically Hackensack University Medical Center ED. And they looked at the sample size of 102 patients, patient charts that met their criteria. So this compared patients who received opioids versus patients who received adjunct non-opioid analgesics. The primary purpose of this article was to analyze ED prescriber habits, which varied as a result. And secondary objectives assessed pain scores, morphine equivalent units, which are MEUs, and ED length of stay between these two groups. As a result, adjunct or non-opioid analgesics did not provide additional pain control when used for additional pain management or treatments. However, these patients did have a decreased ED length of stay. And the last article that I chose was by Sokoloff et al. Titled, "Is Adequate Pain Relief and Time to Analgesia Associated with Emergency Department Length of Stay?" A retrospective study. Again, this was lower on the hierarchy because it's a retrospective study, and he used over 2,033 adults 18 years or older admitted into the ED. They also had to have verbalizations of greater than 6 out of 10 pain. This was conducted in the emergency department in a Canadian hospital. The study compared ED length of stay times between patients who received treatments sooner, so less than 90 minutes, versus patients who received treatments longer than 90 minutes after their initial entrance into the ED. So the results determined that patients who reported adequate relief versus those who reported no relief, there was no difference in length of stay, even with the types of medications that they received. However, if they did receive treatment sooner than 90 minutes, that actually resulted in a shorter length of stay. Some recommendations for practice: patient outcomes such as pain control, adverse effects, long-term opioid utilization, and follow-up for these issues need to be considered when patients with low back pain are admitted and treated with opioid analgesics in the ED. Treatment of adjunct analgesics may also result in shorter ED length of stay overall for acute pain management. However, standard of care for pain management in the ED was inconsistent and not adequately researched in the studies that I looked through. It was also very inconsistent. It may be beneficial for acute care settings to consider utilizing protocols and procedures to address patients' pain promptly, therefore improving length of stay times in the ED. So in conclusion, overall, there was sufficient evidence to infer that non-opioid medications did aid in decreasing ED length of stay for low back pain patients, and in general, patients who were admitted to the ED with acute pain. However, other variables still need to be considered, and there needs to be more research conducted on the topic to further solidify this inference, especially for patients who specifically had low back pain or very specific type of pain. So this is something I will definitely consider as I progress into a provider role, hopefully. I hope you all enjoyed my presentation, and I look forward to your questions and comments. Thank you.